Okay, so this one, obviously, when we talk about all the different medical emergencies and everything over the course of the program and everything with Paramedic, is we spend a significant amount of time on the chest pain patient. We know in terms of, emergencies, they have it on there. One person has an MI every 40 seconds in the US, right? And these slides aren't that old, so all the statistics are going to be pretty comparable nowadays. But everything for those emergent situations and emergent calls that we get, it seems like chest pain is just always the one that we start with. So we emphasize it a lot. Then we'll go into our difficulty breathing, altered mental status, stroke, diabetic emergencies, right? We're going to work our way through all those chapters, but the cardiac one, the chest pain one is definitely the main one that we talk a lot about. So cardiac arrest, cessation of cardiac mechanic activity. Anybody want to jump in and say what's contributing to cardiac arrest for adults disproportionately in the US as opposed to any other cause? So why do adults go into cardiac arrest in the US?
Blood clots.
Blood clots, so clots building up inside those coronary arteries.
Obesity rates in the US are higher.
Obesity rates, for sure.
Family history.
Family history is a big one, right? That's, I've got a lot of heart disease and obesity and stuff in my family, for sure. Sorry, I forgot to press record. Oh no, recording's in progress still. Never mind. Yeah, so it's heavily diet and exercise induced. We just poor nutritional choices. We start building up that atherosclerosis, that plaque on the inside of our blood vessels. That starts building up and building up and building up in blood vessels, specifically in our coronary arteries, until eventually it's just restricting that blood flow to the cardiac tissue. On the pediatric side, what's the #1 cause of pediatric cardiac arrests? Why do they go into cardiac arrest? It's not from Big Macs like the rest of us.
Respiratory failure.
Good, yeah, it's hypoxia, it's respiratory problems. And then it's not, 100%, but disproportionately we worry about the hypoxia and the respiratory problems in our pediatric patients, before potentially considering other causes. So in the US, it's got their, EMS treat about 60% of out-of-hospital cardiac arrest each year. There's a lot of different metrics and things that they look at with this type of stuff. They look at cardiac arrest out of hospital versus cardiac arrest in hospital. In hospital response times, generally there's people right there. So if somebody goes into cardiac arrest, somebody's right there. Hopefully, ideally they notice that right away. Pre-hospital, we've got response times, times somebody found somebody down already. So it's not as straightforward in that out of hospital scenario. And so they kind of look at the statistics for out of hospital, and they look at some of the same statistics for in hospital. So that can kind of skew it when you see, in hospital cardiac arrest saves, those percentages being higher potentially than out of hospital cardiac arrest saves. Just makes sense because it's almost instantaneous. And there was one study that I saw, or an article that I read, that they said they do a lot of cardiac arrest, pre-hospital cardiac arrest studies with Las Vegas. Anybody have any guesses on why Las Vegas would be a prime location for evaluating pre-hospital cardiac arrest?
Stress from spending too much money.
Too much money.
Lots of tourists, there's people, security, AEDs everywhere.
There's a boatload of AEDs all over the place. That's the pretty good part about casinos and other kind of government public buildings, is generally they have a decent number of AEDs all over. Running with that idea of the casinos, what else would make it very easy to study pre-hospital cardiac arrest treatments?
Surveillance.
Yes, that was it actually, and I had never actually considered it, but there's so many cameras everywhere in there that if somebody goes into cardiac arrest, they have 15 different camera views that are catching what time did the crews walk in the building? How long did it take them to get there? What was the time of the treatment and everything on scene? It's just so well documented by all the cameras that are around. So it really makes it easy comparatively to get exact times. What was the exact time that they administered epi? What was the exact time that they defibrillated patients? As opposed to, like, if we ran a call, around, Mesa, for example, and the only times that get reported are the times that we wrote down, which we do our best at tracking and making sure that it's accurate. But, depending on the nature of the call and what's going on with them, we do our best. Sometimes we may slip and not catch, exactly every single time for it, but we kind of piece together the call afterwards. In hospitals, better, because generally you have that nurse that's there in the code bay, that all that nurse is doing is saying, hey, it's been 3 minutes since the last epi, and they're sitting there, they're just charting everything that's been going on. So they have the added resources that we can peel off somebody in those situations usually to be available to just document the thing. Pre-hospitally, fewer providers on scene, so we may not have as many extra hands that we can just dedicate somebody to tracking like that. So definitely some interesting stuff. In ACLS, when we circle back to that stuff, they do a lot of like door to balloon times. Hospitals track that as well. So from the time the patient either walked into the ER because they were checking themselves in, or the time that we walked through the door with the patient, how long did it take that hospital, that ER, to get them into the cath lab, right? So they really try to shorten those time intervals as much as possible, just because, everything, they say it all the time, time is tissue, time is muscle. So the more time, the more minutes that are going by, the more tissue we're losing for those MI patients or stroke patients. So those are big kind of statistics numbers that they like to track and keep an eye on. All right, so into the anatomy and physiology, we're going to kind of review back through everything. Hopefully a lot of it you feel pretty confident with, or just becomes a good general review for it. But the cardiovascular system, right, we don't usually too often just talk about the cardiac system. It's cardiovascular just because of how important it is to talk about it as an entire system. So it's everything to do with the heart and the blood vessels, right? So the heart's great, but if we don't have the blood and the blood vessels to be able to distribute it, it doesn't matter what the heart's doing, right? So we always talk about the heart and the blood vessels all together. Obviously, the goal is twofold, right? Deliver oxygenated blood and nutrients to the cells, right? So we have to get the good stuff in throughout the body and then transport the waste products to the disposal site. So we also have to get the bad stuff out. Most of our kind of mental space and everything is always talking about, let's make sure we're getting oxygen in, let's make sure we're getting fluid in, let's get this in, let's get this in. We don't always think about the output side of it, which is we're building up all of these waste products and toxins and things like that. If we just leave those toxins and things to just build up and build up and build up, that patient is going to crash again purely because of the toxin buildup, even though we might be getting in all the oxygen and all the good stuff that we need. So it's a two-sided coin, right? We got to get the good stuff in and we got to get the bad stuff out, whether it's carbon dioxide for us to breathe out, or getting toxins to the liver to detoxify them, or the kidneys to filter them out of the body. Those are just kind of critical components of keeping that overall health of the system in check, is deliver the good stuff and deliver the bad stuff to where it needs to go to get eliminated. And then chemical messengers obviously play a big part of the cardiovascular system, right? Even if we're just thinking epi, right, as a hormone. Right? So epinephrine, designed to get everything working faster, higher, stronger, or the parasympathetic hormones that are bringing us back down on the other side. Right? So a lot of hormones come into play, just depending on what the body is trying to achieve. All right, so heart has 4 chambers. We know the 2 upper atria and the 2 lower ventricles. If we're talking about sides, right, because we'll talk about the top half with the atria and the bottom half with the ventricles, but then we also talk about the left half and the right half for them. So which side, right, left or right, which side is the high pressure side?
The left side.
Left side.
Yeah, left side, right? And you see it, this picture from your book, they actually do a pretty good job. Some of the pictures of the heart, they don't always do the best of jobs, but the cardiac muscle is muscle, right? So if one side or if a piece of that muscle has to work harder over time, then that muscle mass is going to get bigger and bigger and bigger compared to a muscle mass that doesn't have to work as hard, right? And that's what I've said before. The right side of the heart, it only has to pump with enough force just to get that blood to the lungs and the pulmonary capillaries and back, right? So very, easy, just because it doesn't have to actually pump any blood flow that far. The left ventricle, though, left ventricle has to pump blood with enough force to the top of your head and your fingertips and toes, right? So left ventricle just works harder and harder and harder comparatively. So if we just took any of our hearts and we could cut them open, all of our hearts would show that left ventricle being a thicker muscle mass, right? That middle myocardium layer is a thicker muscle mass than our right ventricle, unless we have some other sort of disease process or something going on. And then in the case of chronic hypertension that'll come up in this chapter, if they have just that peripheral vascular disease, the plaque and stuff that's built up throughout their arteries, throughout their whole body, and the heart is having to pump harder and harder just to make sure that it can deliver that blood flow sufficiently. That chronic hypertension is just chronic extra force that left ventricle is going to have to use to be able to pump blood sufficiently. So left ventricular hypertrophy becomes the finding that you'll get with your chronic hypertension patients. And so it's an easier one to see when you're running calls and looking at the 12 lead, right? And 12 leads is where we can see kind of diagnostically that left ventricular hypertrophy, amongst a bunch of other stuff too, but left ventricular hypertrophy is one of them. So if we're asking our patient our sample history questions and they say they have hypertension, which is just very, very common, if it's uncontrolled hypertension or they've been dealing with it for a particularly long period of time, run that 12 lead and you'll see some of those signs of hypertrophy. Right? Usually how it shows up on the 12 lead are big, giant QRS complexes, right? So that, QRS complex, the big spike, they're huge, right? They usually start running over each other if you're looking at like V1, V2, V3, really across the vector leads, the chest leads. They have big, giant QRS complexes that just run into the other ones. And like V3 and V6 on the bottom of the 12 lead, those QRS complexes will just run off the pages. It'll just keep going. So definitely the ECG finding that you'll see with that. And it's all just back to the fact that left ventricle has to work so much harder, just comparatively. So right atrium receives blood flow from the superior and inferior vena cava. I'm going to shift over to an anatomy app that I have on the computer. It's one that is pretty cool. I just downloaded it the other day. It's been on my radar a few times. Let's see if I can find it here for you. If you're looking for, if you wanted to download it, see if I can get it here. It's Complete Anatomy is the app. I think you can do like several days for free. They have a bunch of different tiered things. I paid for like the educator level one, which I think I can build courses and stuff with it. But they have other ones. They have student versions and they have free ones that are there. So this one, you can really, isolate any organs and start removing tissues and parts of it. So if we just started kind of peeling back just to get our bones out of the way, we're isolating it down to get the lungs out of the way, isolating down to just the heart and the blood vessels. Then we have a nice ability in here to really kind of go through and piece through a lot of different views of it. All right, so if we're just talking about the right side of the heart here, we have the right atrium. Sorry. There we go. So we have the right atrium here. They have a lot of, further sub breakdowns of anatomy that we don't usually get into. But this whole tissue chunk up here is the right atrium, and the right ventricle is what we're seeing. So we're looking at it pretty much from the side of the body. Make sure. Cool. Perfect. All right. So these blood vessels that are going here, these blood vessels that are going here are the branches over to the brachial artery and brachial vein going down that right arm. So we're looking at that patient from that right side. So if we start just hiding some of these tissues, we get to see the internal structures of it, right? So this is removing the wall of that right atrium. And so what we get is the entrance point of the superior vena cava and the entrance point of the inferior vena cava all just dump and merge together right here into the right atrium, right? So everything we know just funnels into that one spot. And if we're looking down through it, what valve do we have here between the right atria and the right ventricle below it?
Tricuspid.
Good. Tricuspid, which they have, laid out here. You can actually see the three flaps of that tricuspid valve. Right? So when the atria contract, right, you get that atrial depolarization. Atria contract, that tricuspid valve opens up to allow that blood flow to actually get down to that right ventricle. Zoom out just a touch. So if we remove the wall of the right ventricle, we can kind of see what's going on in here. So now we're looking kind of up through the right ventricle, and we see the tricuspid valve there coming from the right atrium. What are the names of all of the little white strings that are there that are supporting the tricuspid valve? May remember the name for those? So those are the chordae tendineae. Those will come back up in the chapter when we shift back over to that. But the chordae tendineae, some people say the heartstrings, right? Those chordae tendineae are anchoring the flaps of that tricuspid valve. It's anchoring it down to the wall of the ventricle, because otherwise the ventricle is going to pump with so much force that if we didn't have these anchor spots here, the tricuspid valve flaps would just open back up, and that blood from the right ventricle would go back up to the right atrium, as opposed to out to where we need it to go out. Right? So we have to have some anchoring tissue there to prevent that valve prolapse, is what we would call it. And so in the case of these three flaps that we have for the tricuspid valve, prolapse could be just one flap opens back up to the atria, or all the flaps open up to it. And then they may try to manage that with medications, or they can actually go in and do valve replacements, right? So if they have a particularly damaged valve, maybe they go in and they can implant mechanical, man-made valves, or they can implant, I think, pig and cow valves, as well as another one that they could actually go in and they'll sew it into our heart, and they'll attach the little chordae tendineae to anchor it back in and replace a valve that way if it was structurally damaged or diseased or something was going on to it. On the inside layer of the heart, we have those kind of muscle anchor spots that show up. Those are called your papillary muscles. And again, they just kind of serve as the anchor spot on the ventricular wall for those chordae tendineae that are anchored on the other side to that tricuspid valve. Okay. If we, let's see. All right, so now looking upstairs, when that right ventricle contracts and we close off that tricuspid valve, then the other valve that opens up is this valve. And so what valve is receiving the blood flow from that right ventricle? We got it. We got it. So
Right semilunar.
What's that?
The semilunar valve.
So generically, we call it a semilunar valve. Absolutely, right? And you can kind of see it when it opens up. It makes that little half moon shape, right? It's that half moon shape that we're talking about. It's pulmonic valve specifically, right? So pulmonic valve is a semilunar valve, right? But this one is the pulmonic valve specifically that it's going to go to the pulmonary vasculature, right? Going over to the lungs. The umbrella generic name for the tricuspid valve on the right side and the bicuspid valve in the left ventricle are AV valves, atrioventricular valves. So we have tricuspid and bicuspid or atrioventricular valves, and we have the pulmonic and the aortic is the other one that we'll see in the left ventricle. Those are semilunar valves. And it's just referencing the shape of the actual flaps. Whoa, a little bit too close there. All right, so that's that right ventricular wall, which is another one. It's a good idea to think about it in terms of when we talk about the leads 2, 3, and AVF on 12 leads are suggestive of, or are looking at what view of the heart, 2, 3, and AVF on a 12 lead.
The right side of the heart.
Yeah, it's suggestive of the right side. And initially, though, it's the inferior wall, right? And so we're looking up at the heart from the bottom, right? And this one, you know, shows it pretty well. If we're looking up at the heart straight up from the bottom, right, this is the wall of that right ventricle, right? That's why we think that leads 2, 3, and AVF are suggestive that it could be a right ventricular MI as opposed to a left-sided MI, which is what we normally would assume. The inferior view of the heart has that, you know, again, high likelihood of picking up the right ventricle, which is why we think that it's going to be right ventricular in origin. But at least it's cluing us into that fact initially. All right, so we're going to flip over to the back of this patient, right? So we can kind of zoom in here. So we have the pulmonic valve, right? And the pulmonic valve is sending blood into what blood vessels? Right? Pulmonic valve sends blood into what blood vessels?
It's pulmonary.
Yep, pulmonary what?
Pulmonary arteries.
Pulmonary arteries, right? And remember, arteries are away from the heart, so the pulmonary arteries are taking this deoxygenated blood that came back from the body, and it's pumping it to the lungs, right? And so it starts going for looking at the backside here. Give me. All right, let me remove my arteries for a second, or the other ones. So what we see is this part that shows up in pink there. All right, that's the branches off for it. And we just followed it around. All right, so that is the start of the pulmonary artery system. That's then going to branch to the right and left lungs. It's going to do its whole oxygen process there in the pulmonary capillaries, right? Off gas the carbon dioxide back into the alveoli so that we breathe it out. And the oxygen that we brought in is going to diffuse across that alveolar membrane into the pulmonary capillaries, which are then going to circle back into the heart through the pulmonary veins, right? Because it's bringing blood back from the lungs back to the heart, so they're veins. In this case, it's oxygenated blood is what we're seeing. And we can hide my left atrium wall here. Let's see if I can get a better view of it. And, whoops, sorry about that. So left atrium then receives the blood here. Again, just like on the right atrium side, it's those 4 pulmonary veins come back and just dump all that blood directly into the right atrium. In the right atrium, let me just circle this all around. I had that one as well. White atrium, or the left atrium, sorry. Left atrium sends the blood through the bicuspid valve or the mitral valve. So this one only has those 2 flaps, similarly anchored by the chordae tendineae to the papillary muscles on the inside of the ventricular wall. So the blood flow from the left atrium down to the bicuspid valve to the left ventricle. And we're going to kind of do a weird angle here to get to it. There we go. Then hiding up in there is the other semilunar valve, that aortic valve, which then is going to take that blood through the aorta out to the rest of the body to deliver that freshly oxygenated blood that the heart just got back from the lungs. That left ventricle pumps that blood out the aortic wall or out the aortic valve throughout the entire body. So again, kind of interesting way to look at it and be able to manipulate it with some of these apps and things that are out there. You know, just to again help highlight the difference on the left ventricle wall and the right side, or the right side and the left side. Some of these apps can really help, you know, with zooming in and playing around and looking at it from different angles to really understand what's going on, that sometimes our book really uses or loses just with the pictures that it's showing. All right, let me flip back over to my PowerPoint here. That's my son. Hey, buddy. All right. All right. Cool. All right. So a lot of these slides is just that walking through that we just did through the various structures of the heart. But I can't emphasize enough the importance of being able to really map through all of the structures if we were just following a red blood cell through it. So if we said, you know, red blood cells, inferior and superior vena cava into the right atrium, through the tricuspid valve to the right ventricle pumps it through the pulmonic valve to the pulmonary arteries, pulmonary capillaries, pulmonary veins, left atrium through the bicuspid valve, left ventricle, out the left ventricle, out the aortic valve to the aorta, out through the whole body. So it's such an important thing to understand the normal forward pathway of that, so that when we get to the CHF patient and we say, okay, now the left ventricle is not working. So if the left ventricle is normally pumping blood out the aortic valve, now it's not pumping it out the aortic valve, so it's going back up through the bicuspid valve to the left atrium. And if it backs up there from the left atrium, it's going to back up into the pulmonary veins. And then in the pulmonary veins, it's going to back up into the pulmonary capillaries. And that's where that pressure just builds up and it starts to squeeze some of that fluid into the lungs for our pulmonary edema. So it's such an important understanding of what's normal forward. So that if we say left isn't working, you can work your way backwards. Or if the right's not working, you can work your way backwards. So very important that you kind of map through and understand those just processes for it. All right, so right side and left side, right atrium and right ventricle, like we said, it's a lower pressure system, and it's the pulmonary circulation side. All right, so its whole purpose and function is to just receive that blood from the body and deliver it to the lungs. That's the whole reason why that right side exists, is to get the blood to the lungs so that the lungs can get rid of the carbon dioxide and bring in the oxygen. On the left side is the high pressure system. It's the systemic circulation side, which is, again, the left side's whole purpose and function is to generate our pulse, right? It's pumping blood throughout our entire body so that we can actually deliver that oxygenated blood throughout the entire body. All right. So walls of the heart, right, like a muscle, like most everything else in the body, it has 3 layers that we talk about. So the myocardium is the middle layer. It's the layer that we talk about the most. It's the big, thick muscle mass layer of the heart. It's the one doing all the work, right? So when we talk about the workload of the heart, when we talk about what is trying the heart, is it what's doing the most in terms of the pumping mechanical process, it's that big, thick myocardial muscle layer. It's the middle layer. That's why we say a myocardial infarction, right? Because if the heart's not going to get enough oxygen, the piece of the heart muscle or the heart wall that requires the most oxygen is going to be the part that's working the hardest. So it's the myocardium. You can have endocardial MI or an epicardial MI for the middle or the inner layer or the outer layer. It's just way, way, way less common. Most often, if you get MI that's actually progressing through like the epicardium layer or the endocardium layer, it's just a really, really bad, really, really progressed myocardial infarction. Just now that dead tissue part has been spreading as the surrounding tissue doesn't get enough oxygen either. So myocardium is the big, thick muscle mass inner layer. In a minute, we'll talk about blood vessels, right? Blood vessels have 3 layers as well. One of the layers is a muscle mass to allow blood vessels to constrict and relax, to vasoconstrict or vasodilate. The muscle mass for blood vessels is the middle layer as well. If you go to the uterus, right, and talk about the uterus being a muscle that can contract to deliver the baby, it has endometrium, myometrium, and epimetrium are the 3 layers of the uterine wall. The middle layer, the myometrium, is the big, thick muscle mass layer as well. So when you have those 3 layers, we have kind of an inner protective layer, an outer protective layer, and then the muscle mass side, the muscle mass on the inside. All right, so coronary arteries, these have started to really come up in the rhythm identification section and certainly the 12 lead section, because for us to say this person is having an anterior MI, means it's showing up in those particular leads on a 12 lead, but it also allows us to then take the next anatomical step and say, okay, if the left anterior wall is not getting enough blood flow, the way that the coronary arteries work, we have the right coronary artery wraps around the right side. We have the left coronary artery that wraps around the left side and then goes down the front. So for 70–80% of the population, the way their anatomy works, if you're having an anterior wall MI on the left ventricular wall, it's the left anterior descending coronary artery is one that has that plaque buildup blockage that's cutting off blood flow. So this slide is a good one, and your book gives it to you as well this way. The left main coronary artery supplies the left ventricle and the interventricular septum, right? So that wall bridge between the right ventricle and the left ventricle gets perfused by the left main coronary artery and its sub-branches. Right coronary artery supplies right atrium, right ventricle, maybe parts of the left ventricle, and then portions of the conduction system. So that's one that I've said before in the rhythm identification section, that the right coronary artery, just because it wraps over and perfuses that right atrium territory, it also perfuses that tissue where the SA node is at. So if the SA node isn't getting good blood flow, then that SA node's not going to work as well. And electrically, if it's not working as well, it means it's going to be going slower, right? So you may have more of a tendency to set into bradycardia for those right-sided MIs, just because of that blockage of the blood flow to the piece of the right atrium that has the SA node in it. So looking at the 12 leads and all the stuff that you guys did 2 weeks ago with Corey in that chapter, I believe, the left-sided MIs, because the SA node is still able to function properly, your left-sided MIs, the patient is more likely to go tachycardic and more likely to go hypertensive, at least initially, because the body is able to try to compensate for the fact that the heart muscle isn't getting enough oxygen. So that SA node is going to say, hey, something's not getting enough oxygen. The brain's sending the signal down to the heart to say, pump faster, pump faster, pump faster. So the SA node starts going faster. So you're more likely to go into tachycardia with the left ventricular MIs. On the right ventricular MIs, you're more likely to go bradycardic, and with the bradycardia will come your hypotension as well. It's the #1 reason why we say if it's a right-sided MI, if you're suspicious of it being right-sided, withhold nitroglycerin. Right, we'll say nitro is a contraindication for those right-sided MIs, because if they're not hypotensive already, which there's a decent chance that they'd be hypotensive already, we know that's the direction that they're going to progress. So we don't need to expedite that for those right-sided MI patients. They're going to be bradycardic and hypotensive more than likely. But if they're not hypotensive yet, like I said, we'll still withhold the nitro for them. It's really for those left-sided MI patients that nitro can be particularly beneficial. And again, that's just the initial response. Right? A bad enough left-sided MI, eventually the body will start failing. It'll start losing its compensatory mechanisms and the hypotension will set in. But at least initially, left-sided hypertensive and tachycardic, and right-sided hypotensive and bradycardic. So it could be one of those kind of test questions where they give you patient scenario, patients complaining of chest pain, they're pale, diaphoretic, difficulty breathing, nauseous, the classic symptoms, chest pain radiating down the left arm or to the jaw, the classic MI symptoms. And they give you a set of vitals, and the vitals are 80/40, heart rate of 55, SpO2 92%, respiratory rate 26, right? Just based off the vitals, if we say, hey, the description of that patient, they look like they're having an MI. Now they're hypotensive and bradycardic. If the question's not, what do you think's going on with them? Like the answer is more than likely going to be an inferior wall or a right-sided MI, just because of the way that they'll give you those vital signs in the classic kind of stereotypical presentation, which is always the place that we're going to start initially. All right, so there they are again, and it helps on this one because they throw in the coronary arteries and coronary veins. So what it is as soon as the left ventricle pumps blood into the aorta, let me get that here. So as soon as that left ventricle gets blood into the aorta, there's the immediate offshoot that you can kind of see right there. There's an immediate offshoot of that coronary artery that will go back and deliver blood flow to the heart itself, right? So the very first place, as soon as the blood gets pumped from that left ventricle, there's an immediate little avenue that allows the heart to perfuse itself first before the rest of the blood continues into the aorta, going to the upper body, going up to the head, and then continuing down to the lower half of the body. So the heart kind of protects itself first, and it immediately delivers some of the freshly oxygenated blood that the left ventricle pumps, immediately gets delivered to the muscle mass of the heart itself. Even though we have all that blood moving through the inside of the heart, the inside wall, the endocardium, that inside layer is not absorbing oxygen into the tissue, right? That oxygenated blood to perfuse the heart has to come through the coronary arteries, and then the smaller and smaller little branches down, just like blood vessels anywhere else in the body. Okay. How am I doing? Let's see. Abby, can we repeat vital findings for the right-sided MI? Yes. So sorry guys, I keep minimizing the part that has the chat and the screen. So just chime in and say, hey, got a question? Just so I can know, otherwise I'll try to keep going back and forth and checking them. So your vital sign findings for right-sided MIs, hypotension and bradycardia for right-sided. For left-sided, hypertension and tachycardia, right? So heart rate and blood pressure go the same direction, which is down for right-sided, and the same direction, which is up for your left-sided. Any other questions kind of initially right now? Good review, too fast, too slow, too dead? No, not ACLS stuff. Doing all right? Cool. What was the app you used? The one that I downloaded is called Complete Anatomy. It looks like, let's see, where is it? So, yeah, it's Complete Anatomy is the one that I use. There's several out there. If you just go to the App Store, you can find quite a number of them there. That is one that had just been referred to me a couple times. I think Tyler Bittner was the first one that told me about that one, so I just jumped at that one. I didn't spend too terribly much time kind of looking into all of them. That one just seemed pretty cool initially, so I used that one. All right. So we'll get back into this. Cool, still recording. Wanted to kind of bring you some updates on some stuff. So it's just constant emails from, DHS and National Registry and everybody right now. So I just got one that isn't even announced yet, but it's the one that we've kind of been sitting waiting for. But the AHA is going to announce next week their accommodations to kind of officially allowing distance learning like this for CPR and everything. And they're going to issue provisional certifications if anybody doesn't have a place that is doing skills in person to be able to kind of officially meet the criteria for that. So I don't know if it was somebody from this class or one of the other classes that asked me about renewing their CPR. AHA next week, like I said, they're going to announce a bunch of accommodations and allowances for this type of stuff. And so then that'll kind of settle some answers for how we can best do ACLS for you guys kind of officially with their approval. DHS yesterday announced that they have some waivers in place that are valid for the next 90 days. So I don't know how much will impact you guys yet, but it's something that we're kind of digging into, the regulatory side of everything. But DHS has some waivers regarding the set required number of clinical and vehicular hours for paramedic programs to be able to graduate. So there's some potential changes that could come along. We still have a lot of time with you guys, but in the event that this thing really goes crazy and it's a long time before we can get you anywhere, we still will as soon as we can, but DHS is making accommodations to not delay stuff further to to my understanding of how I read it yesterday. So more stuff from them. National Registry, the Pearson VUE testing centers last week had shut down their testing centers, so nobody could go test for registry. The other day, Pearson VUE said they were going to open back up on a limited basis for essential people that needed to get certified. So it's EMTs, paramedics, nurses, any of those types of professions that need to be able to test to get certified. Right now, Pearson VUE is open for us, for you guys, which is the important part. Again, we have a lot of time with your guys' class, but still was definitely reassuring to hear that they were going to open back up for you guys and not have any, issue with that. But either way, registry was going to be coming up with some sort of pathway for people to get certified.
We have time right now, but if it continues, it's going to set us back quite a bit. So we have time right now, but if this madness continues even 90 days, that's going to really start setting us back with clinicals.
Yeah, which is why, DHS said, like, they're waiving that requirement right now, which is good on one hand, but then, bad on the other hand, which is you guys don't get those opportunities and experiences if it went on for a really long time. Now, even if it got to that, I would figure out something just on the school side to, even if we completely, in November, we graduated, you guys got out there and could start doing stuff, and hospitals still weren't open yet, but then they open up in, November or December, and you guys wanted to do clinical shifts, like I would get you guys scheduled to get more experience and exposure that way. So either way, we'll make it work for you guys, but hopefully everybody's desperately hoping to, one, be back in person at the school. I prefer lecturing in person and having the skill stuff right there readily available. But then most importantly, I want to get you guys into the hospitals and stuff as soon as we can. All right, Abby, so we have to have ACLS served before clinicals can start. Yes, that's always how we've had it, and that's how the hospitals have had it, which is ACLS is that benchmark day to say you pass ACLS, and everything prior to that means we can get you into the clinical shifts. Now, what'll happen is we'll get, on the school side, we'll get lead time on when they're going to open up, because there's still the My Clinical Exchange compliance that'll be in place, and they'll still have all of that type of stuff there. So the hospitals won't contact us and say, hey, you can send students tomorrow. They'll say, hey, in 30 days, you can send students, so you can schedule now. So as soon as we get that message, we'll get with you guys immediately, because you guys are first up. And we'll say, hey, hospitals are going to open up in 30 days. If you feel like you're ready, feel like it's safe to go to them, then let's get you scheduled. Let's get you on the books right now. And in that time, hopefully long before that with the AHA, but in that time, we'll have all the ACLS or any sort of that type of stuff satisfied. But that won't hold you guys up at all. Off topic question, are we able to start our vehiculars ASAP if we know of any departments or AMR that will allow vehiculars? Let me get back to you guys on that. Let me get back to you on that. AMR is still taking people, but they have the AMR class that's going through right now for vehiculars. Most of them were done with their 10 ER shifts already, so it wasn't an issue. And so now we're crossing that bridge with them for some of the people that had 8 ER shifts, but then got shut out, just the timing of it. So let me get an official answer on some of that type of stuff. And then that can then roll over to you guys, where we may be able to cycle through some vehiculars and just do a little bit of stuff out of order, just to kind of get you out there and get you into that environment. Again, right now it's heavily, I'm putting it on each student individually, that if they feel comfortable going out there, they can, if we schedule it, if we figure out how it's actually going to work. Just It's not, we're not forcing somebody to go if they don't feel safe in the current environment out there. All right. Ben, what should we do if our EMT cert expires next month? State or national, Ben? State or national? I guess if it's next month, it's state. So Ben, you can go online right now for the state, the ems.azdhs.gov, and you can click to create application, and it's the renewal of certification is the application, and you verify criminal history, your address, that type of stuff. And then it says, how did you recertify? One answer is the traditional EMT refresher course. The second option is you recertified your national. And then the third option is you have CPR and enough continuing education hours, which all of you guys, for just being this far into the paramedic program, you get hour for hour for all of the class stuff. So click that third option that says something along the lines of CPR and continuing medical education sufficient for a refresher or something like that. It should be the third option on there. And then you just click that one and click submit and you're good to go. I literally just did mine yesterday morning, and there's the same one for paramedic. It's that, BLS and ACLS and continuing medical education. Click that one, they approved it within like 3 hours. If DHS ever audited you, then all you would have to do is, here's my syllabus for paramedic school, and they'd be like, okay, cool, that's it. So it'll literally, Ben, it'll take you 4 minutes once you get logged in. It's very, very fast, and they'll, like I said, yesterday they approved mine within about 2 hours. So very easy for that one.
Andrew, this is Carrie. Actually, if your national registry is current, you can use that too. Even if it expires like the end of this month.
Yeah, registry extended. If you have a March 31st deadline for registry, they extended it to June or July, I believe. They're giving an extra time allowance there for anybody to meet the recertification requirements. State's just very easy because you don't have to plug in anything.
Yeah, the state will just, I think there's an option too that says use your national registry. And even if your registry was to expire like tomorrow, if you do it today, they're still going to accept it and give you your certification for 2 years.
Yeah. Oh, any other questions on any of that random stuff? No. All right. If you do, don't hesitate to ask. All right, so back to our heart. Oops. All right, back to our heart. So hopefully we'll feel pretty good with that. The ECG's Made Easy book, if you flip back through that one for the coronary artery section, they really break it down and say in 70% of people, the left coronary artery or the left anterior descending coronary artery perfuses the left anterior ventricular wall. And 30% of people, that same coronary artery actually perfuses this other spot, right? They really break it down, just kind of the demographics of most people, this coronary artery perfuses this section, but in some people it perfuses this other section. That's some pretty in-depth stuff. The place I would say to start with that is the majority, right? What's the majority of people have perfused by that particular coronary artery? Or even more generically is this slide that we had just left previously. The left main coronary artery supplies the left side, the right main coronary artery supplies the right side. Start there. And then again, like I said, keep in mind that that right coronary artery covers the SA node as well. So that's why you get the bradycardia there. All right, so cardiac cells have 4 properties that help the heart function. So this stuff is going to, ring true and ring over from the ECG's Made Easy section, all the cardiology stuff that we did, all the electrophysiology stuff that we just did. So automaticity, that's one that I'm sure everybody's just tired of hearing that word by now. Automaticity, we know, is just that principle that any cell in the heart could be the one to decide it wants to start firing. So every cell has that capability. Some are more readily going to do it, right? Like the little bundle of cells there for the SA node. They have automaticity as well, just like the AV node, just like the bundle of his, just like themselves in the ventricle and the atria, all over the place. They all can initiate impulse. That's why when you see like AFib, right, it's all those different cells up in the atria are firing off electricity, right? There's no coordination to it. They're all firing. Same thing in VFib, right? All the cells in the ventricles, like so many of them are just trying to fire off electrical signals because they can, right? Now, generally they don't. Something has to be going on that kind of is pushing the heart into that territory. And sometimes we use that second word, excitability or irritability. The more excited a cell is, if you just thought about sitting there, like you're excited, can't wait for 5 o'clock for lecture to be over, and you're just chomping at the bit, ready to go, right? As soon as something happens, you're out of that chair, you're ready to go. So cardiac cells have that potential too. The more excited that cardiac cell is, or the more irritable it is, as soon as something triggers it, bam, that cardiac cell is going to start firing, right? So excitability is a scale, right? A very low excitability cell, you know, it's going to take a lot to get that cell to try to start firing, right? It just, everything is going perfectly clean and healthy and smooth in the system, right? You're just not going to get this cell to get irritated and start firing off, right? But in something like an MI, where cells are now, you know, a lot of cells aren't getting enough blood flow, aren't getting enough oxygen, more and more cells are starting to get a little more anxious, right? A little more irritable, a little more excitable. And now the condition just worsens that a little bit more, and they go into VFib and everything starts firing, right? So that's excitability. Conductivity is obviously the electrical conduction system, right? It has the ability to kind of conduct, transmit that electricity, ideally through that coordinated system that's there. Some cells are more highly conductive than others. Dead cells are not conductive whatsoever, right? So if somebody has that dead tissue spot from the infarction, right? When the electricity traveling through the heart hits that dead tissue spot, it doesn't work its way through because you can't get those dead cells to depolarize. So that electricity hits those dead cells, and now it's got to kind of redirect and work its way around. And that's where you'll get some of those like bundle branch blocks and those intraventricular conduction delays, and you'll get some funky shaped QRS complexes. Is something was going on down in the ventricles that caused the electricity to stop and have to redirect. And so as soon as you get that direction change of that electricity to work around that tissue, you're going to see the notching and stuff showing up on the QRS complex usually. And then contractility, you know, we know the actual strength of the contraction force. So as muscle cells, they have that ability to contract and relax. Hopefully just 4 good definitions to have some comfortability with. Cardiac conduction system, we know this, right? We've been doing a month and a half of this stuff just about. And so you can kind of follow through that part pretty well. On the nerve stimulation side, we have the sympathetic nerves, right, which we know if we're going back to our alpha and beta 1 and beta 2 sympathetic nervous system receptors. We have a high concentration of those beta 1 receptors in the heart. Remember, beta 1, you have one heart. So it's all the cardiac effects. So when you stimulate on the sympathetic side, when you stimulate those beta 1 receptors, you get the increased force of contraction, the increased contractility. Anybody remember the fancy name that we give for the increased contractility effect?
Inotropy.
Good, yeah, that inotropic effect. Very good. Yeah, that positive inotropic effect is specifically just referencing the force of the contraction. So remember, we can talk about the heart going 60 times a minute and weak, right? Or 60 times a minute and strong, right? The rate is the same, but the strength of that contraction is a lot stronger. So the stronger the contraction, the stronger it's going to push out that blood, means the stronger or the higher that blood pressure is likely going to be. So the inotropic effect is the contractility. The fancy name for increasing heart rate.
Chronotropic effect.
Chronotropic effect, right? That's where most of us, right? If we take our watch off and look on the back of our watch, most of them say chronometer, right? Chronos, right? The root chronos of that word references time. So a chronometer, a watch, is a thing that measures time, right? Meter is time measuring, and chronos is time. So that's a chronotropic effect. The third one that they don't have there is the one that we talk about the least, which is why sometimes it falls off of these slides. But it increased speed of electrical conduction, or speed of electrical velocity, right? So how fast that electricity moves through the heart. What was the fancy name for that one?
Dromotropic.
Good, dromotropic. Good, dromotropic. So dromos in Latin or whatever is running, right? So we're talking about the dromotropic effect. The electricity is running through the heart. The electricity is being conducted through the heart. Good. The reality is there's some beta-1 receptors other places in the body too, just the majority of them and the response that they have are all going to be cardiac. Just like beta-2 in our lungs, right? We have 2 lungs. So beta-2 is bronchodilation. There's beta-2 receptors in the heart as well, but the bulk majority of those beta-2 receptors are in the lungs. And then just I can't ever go beta-1, beta-2, and alpha and not make sure I hit all 3. So if you stimulate your alpha receptors, what happens?
Vasoconstriction.
Good, good, good. Vasoconstriction. Awesome. All right, on the parasympathetic side, specifically talking about cardiac functioning, what's the main parasympathetic nerve?
The vagus.
Good, vagus nerve. And so cranial nerve 10, the vagus nerve, right, goes down to the heart and specifically goes down to like the SA node, right? And so in like heart transplants, right, they have to take somebody else's heart out and put somebody else's in, they'll cut that vagus nerve. And so they're more likely to have some SA node issues potentially. Although as medicine has gotten better, now they've figured out they can reattach some of those nerves and things like that. But the vagus nerve is the big one for cardiac functioning and specifically rate. And so we know we use the vagus nerve intentionally in our ACLS tachycardia algorithm, because if you stimulate the vagus nerve, heart rate slows down, right? Stimulate any of our vagus nerves, heart rate slows down. So if the heart rate is going too crazy fast, 220 SVT, and we want to slow that down, right? If we can get them to do a vagal maneuver, like blowing the plunger out of the syringe or something like that, then we can get the heart rate to slow down that way. The vagus nerve stimulation only becomes an issue is if their heart isn't elevated, right? If their heart rate is normal and they vagal, that heart rate's going to bottom out and that blood pressure is going to bottom out, right? Sometimes we, kind of facetiously use that term commode code, right? Somebody goes into cardiac arrest in the bathroom. Sometimes you get it's those constipated patients, elderly patients that are, they're bearing down, trying to have a bowel movement. And in that bearing down process, they stimulate that vagus nerve and heart rate drops off, blood pressure drops off, and it bottoms out so much that the system collapses and they code because of it. So that's kind of the power of the vagus nerve. It's good when the heart rate's fast. It's not so great when the heart rate is normal and then we lower it down too much. Some of them on the pediatric side, just another place that you can stimulate the vagus nerve is putting pressure on the eyeballs, which is not a standard practice vagal maneuver that we're allowed to do. You can't just go up to your SVT patient, just dig your thumbs into their eyeballs. You'll get in trouble for that. But it would probably work. We're just not allowed to do it. But where that comes into play a little bit more practically and inadvertently is if we're doing blow-by, with an infant, a pediatric patient, the pressure, if we have blow by at like 15 liters per minute, just that high pressure air blasting at them, that high pressure air, if it's pushing on their eyes, can actually stimulate that vagus nerve for an infant. So it's something that we got to be careful about, and that's why we'll dial back our blow by oxygen to maybe like 10 liters per minute, just because literally just the pressure of it can be enough to stimulate that vagus nerve, and then the kid's heart rate starts slowing down. Another one in pediatrics is if you're bagging the kid and you have too big of a face mask, and that face mask is being pressed into their eyes, coupled with the high pressure air that we're bagging at them, that can be enough to stimulate the vagus nerve for a pediatric patient as well. So sometimes we run into it inadvertently with the little ones, as opposed to kind of intentionally trying to get an adult SVT patient to slow down their heart rate. All right, so primary survey, I mean, Andrea just hit all that stuff with you guys on the CBC, LOC, ABCs. So nothing is different there. It's literally just recognition, first and foremost, of do I think my patient's dead? If yes, check a pulse right away. Right? It's the first thing, most important thing we have to know is whether we have to start pounding on the chest. Once we've crossed that bridge of they're not dead, either visually we can just see, like, patient's alert and talking to me, so they're clearly not dead. Or even if they were altered unresponsive, we go up there, check that pulse right away, find out they're still alive. Then we just carry on with our classic A, B, C, and work our way down. Right? ABCs, O2 IV monitor. Right? So history taking, right? We're going to get into all the different disorders and stuff like that during this chapter. But history, sample history is key, right? Generally speaking, somebody doesn't just out of the blue one day have an MI that didn't have some sort of history leading up to that point, right? You don't have just a perfectly healthy person that had a spontaneous MI and is otherwise healthy completely, right? Something is going on, right? Something had to cause that. So sometimes they may not know about it, which is an aspect. They might not know they have that atherosclerosis, chronic hypertension, because they never go to the doctor. They've never been evaluated. So that would be possible, right? You ask them your sample history questions and ask about any past medical history, and they say, none. When was the last time you went to a doctor? And they're like, physical in high school? I don't know. They just never go to the doctor. Like, it's certainly possible in those situations that they might not know. But generally speaking, that sample history and the past medical history, usually there's something there that's contributing to it that will kind of tell us, like, hey, yeah, we think this is related, right? Or inevitably just asking that question, have you ever felt like this before? And then if they say yes, you say, what happened? Did you go see a doctor then? If they say yes, then just keep following down that trail and just saying, okay, well, what did they say? What did the doctor say? They say, oh, the doctor said I have this crazy disorder. You're like, okay. And this feels just like that? Yep. I'm like, okay, cool. Like, I'm going to say this is just an exacerbation or a continuation of that problem, right? If you tell me this feels just like something that you felt before and they gave you a diagnosis for that, I'm going to assume that those two are the same thing again. Right? So in this whole cardiac section, kind of initially we use that whole ACS term, which most of the time we fall into that just chest pain protocol terminology, like that's a chest pain patient. The better technical answer and the textbook terminology that they would like us to use is that acute coronary syndrome, right? That chest pain protocol for the American Heart Association for ACLS, it's an ACS protocol. They use that ACS term there as well. So in that one, it's a series of cardiac conditions, right? It can be a bunch of different ones that all result in just reduced blood flow to the coronary artery, right? So whether it's angina up to a full-blown STEMI, they're having some issue that's reducing blood flow through the coronary artery, so it's cutting off blood flow, or at least reducing that oxygen delivery to the myocardium itself. So the angina, unstable angina, the non-STEMI, right, non-ST segment elevation MI. So in those situations, we walk in, we take a look at that patient, The patient's chest pain, difficulty breathing, right? They look like they're having a heart attack. We run a 12 lead and we don't have any ST elevation, depression. Like the 12 lead looks fine. And we look at our patient, we're like, you look like a heart attack. You're complaining of chest pain, you're gray, like you look like crap. And we run the 12 lead and we look at the 12 lead, like 12 lead looks fine, right? Get them to the hospital, they'll draw some blood and they'll take a look for those cardiac markers that only get released into the bloodstream if cardiac cells are dying. So they'll test the blood and they'll see those cardiac markers that are saying, hey, oh yeah, cardiac cells are dying, but it's just not manifesting on a 12 lead in these situations. So those are called non-STEMIs, just because you don't get the 12 lead changes. And then the most common one that we talk about the most is the STEMI, where we actually see those effects on the monitor. Good. All right, so chest pain, again, is often the presenting symptoms. Right hand in hand with chest pain is the dyspnea. We just know the cardiovascular system and the respiratory system, they just go hand in hand together. So if you have chest pain, give them a little while, they'll have difficulty breathing too. Right? You give a diff breather a little bit of time, they're probably going to develop some chest pain, right? Just those two organ systems are so intertwined in their functioning that you're likely going to have both, right? So it becomes kind of two of the classic 5 signs and symptoms of that stereotypical MI patient, right? Chest pain and difficulty breathing are the big ones. All right, if your patient fainted, right? So just other possible things that we can take a look at. So there's a 12 lead protocol, I guess you'd call it more or less, in your red book that says kind of what patients you would run 12 leads on. And when you look at that list, it's basically everybody. Like there's just the criteria for it is like, is there any possibility that it could be their heart? And it's like, well, there's almost always a possibility that it could be their heart. So that list, it's not super helpful of a protocol. So flip through it and sometimes just take a look at it. But it's really like, if they have this, run a 12 lead. If they have this, run a 12 lead. Abdominal pain, maybe it's their heart, right? Maybe it's an atypical presentation, run a 12 lead. If they're dizzy, run a 12 lead. Like if they're complaining of this, run a 12 lead. It's just everybody gets one, that they say. Doesn't always carry over into common practice, but you see it a lot kind of in the protocols basis for it. So if somebody had a syncopal episode, they passed out or they stood up and they got dizzy, you say, well, is there a chance that their blood pressure dropped because of a cardiac arrhythmia? I'm like, yeah, for sure. That's a big reason why. So we definitely want to run a 12 lead. And that's what they're saying here with this one, is try to differentiate whether they fainted from a cardiac issue or a non-cardiac issue. And the easiest way is for us to say, is it a cardiac issue, is put them on the monitor and take a look, right? What's their heart doing right now, right? And even if it looks fine right now, that doesn't necessarily mean officially that it wasn't a cardiac issue in the past, right? They could have had an episode of VTAC and that's why they fainted. And now when we get there, we show up, put them on the monitor and everything's sinus. And we're like, dude, sinus, syncopal episode, another one of those calls, right? We get this person that, oh, they fainted, they're probably just dehydrated again, right? We get a little callous, we get a little bit lazy with our assessment. You know, always reserve in the back of your mind that they could have had an episode of something like SVT or VTAC. They could have had an episode of some sort of arrhythmia that just happens to be resolved by the time we get there, right? So put them on the monitor, check them, and then keep an eye on that monitor, right? And then, you know, we obviously, you know, those are a type of patients that, barring something else that really gives us a pretty clear idea of why they might have had the syncopal episode, and then it's usually one of those ones where it's like, hey, you know, we kind of recommend you should probably get checked out, right? Figure out what might have happened, right? And if they say yes, and we're transporting them, leave them on the monitor, right? Because maybe during transport, you look over at the monitor and you're like, oh, dang, that's VTAC. They're like, bam, that's what was going on earlier. Now I've got it, right? Just the fainting ones becomes ones that we get them a lot, and it's all dehydration in Arizona for the most part, right? It's, you know, hypovolemia, people get a little lightheaded and woozy. It's, you know, dehydration is so common here. but don't get pigeonholed with that idea that it's just another elderly dehydrated patient. Give them a fluid bolus, they'll be fine. It's like, nope, it might be the cardiac arrhythmia that they're having going on. All right, palpitations, right, as a complaint is usually tied to a sensation of abnormally fast or irregular heartbeat, right? It's not too often that you get somebody complaining of palpitations and you put them on the monitor and they're bradycardic, right? Just most often, if they say my heart is, if they use that word palpitations or fluttering, right, it's almost always tied to the fast end of it. And then next, after the tachycardia side, is the irregularity, where maybe it's just a bunch of PVCs that are getting kicked out, right? So they're feeling that irregularity a little bit more. But then even with that, it generally starts to tie over into their heart rate starting to creep into the faster and faster side of things. So OPQRST questions, on sample, we always ask these. You know, the chest pain ACS patient is great for OPQRST questions. If they're complaining of palpitations, like, frequency and duration, kind of like when we're assessing contractions and laboring mother or soon to be mother, right? How long has that contraction been lasting and how frequently have they been happening, right? We can ask about something like that for palpitations, like how long does it feel like that? And they're like, it's still feeling like that. It's still going on. Or they say, oh, it was about, maybe a couple minutes and now it stopped. And then it started again, right? So then you can kind of start timing it a little bit and figure out just how often is it happening, right? And just like we have the energy level starts rising for us if we're thinking about we may have to deliver a baby, right? As the frequency is increasing and the durations are lasting longer, right? It would also be a concern level for us if we're talking about palpitations with the heart, which is if that frequency of how often they're having these palpitation feelings is more often and they're lasting longer, right? We're thinking they're more likely going to get kicked over into like sustained VTAC or something like that, depending on what's going on with them. So the more often it's happening and the longer it's happening for, the more concerning it is for us in these situations. And then past history, previous episodes is great. They could say, oh yeah, I went to a cardiologist, they put me on a Holter monitor, and they say every once in a while I go into AFib and they're rapid AFib. Like, okay. Again, just, the simplest answer is usually the correct answer, right? This is probably related to that again. Patients may also report feelings of impending doom, nausea, vomiting, trauma involvement and hypoxia. They may report that. It's a finding that we'll see. Inquire about our medical history for sure. Nausea, vomiting is another one of those classic STEMI chest pain patient signs and symptoms. Right? So chest pain, difficulty breathing, nausea, vomiting. Right? Those are big ones. And then just think, if you start vomiting, right, your heart rate starts increasing and everything, that's now putting more workload on the heart, more oxygen demand on the heart. So it usually starts making that problem worse once they actually start throwing up too on you. The feelings of impending doom is one that, may sound silly or whatever, but until you actually get that patient that kind of looks at you and says, like, I feel like I'm going to die. And then like, that's usually a really bad one. Like when they look at you and it's like, they're serious, like that means something. And then as soon as you see it, and you'll immediately think about this and be like, I get it now. Having that patient just look at you and say, I don't feel good. I think I'm going to die, or I feel like I'm going to pass out. And then shortly after that, they code. As soon as you get that patient, you'll know exactly what that means. But it's usually one of those kind of ominous things, as it gets to that point where they actually articulate, this is how bad I feel. I feel like I'm going to die. Ask about medications, prescription medications, certainly any cardiac medications. And then on the medication part is always you follow it up with compliance to those medications, right? Great, you have all these prescriptions. Have you been taking them as prescribed? Like, well, I haven't got this one filled in the last 3 weeks because I don't have any money. It's like, okay, what was that medication? What was it responsible for? Now we have 3 weeks of not being on that medication. So you can kind of figure out this is what the medication does. So if they're not having that medication on board, then this is probably how they're going to respond. Over-the-counter drugs, herbal supplements, recreational drugs, erectile dysfunction medications, we know for our nitro considerations, we have to ask about those. Past medical history that's particularly pertinent, coronary artery disease. Some patients are like, they're on it, they've been to the doctors regularly, and they're like, yeah, I went to a cardiologist, you know, we did the test and everything, and they said I have a 50% blocked left coronary artery. Okay, how long ago was that appointment? Right, that appointment was last year. All right, so a year ago it was 50% blocked, and now you're sitting here today complaining of chest pain to me. Like, all right, I'm assuming that that blockage has been getting worse, right? You know, tied in with that is the atherosclerotic heart disease. So we have the atherosclerosis, which is the plaque buildup, and then we have the arteriosclerosis, which is the actual wall of the artery itself is getting rigid. You know, it's getting hardened. So as that wall gets hardened, it has less contraction and dilation. So it's kind of just becoming a solid pipe as opposed to a dynamic contract and relax pipe. So it's becoming a solid pipe. So normally if that heart needed more blood flow, it would vasodilate to allow more blood flow to get to it. In this case, it needs more blood flow, but the walls of the artery in arteriosclerosis have been hardening up, so it can't dilate to allow more blood flow. So it's restricting blood flow just because of how rigid it's becoming. Valvular disease, things like mitral valve prolapse, right? So those valves that we have in the heart that keep blood moving the proper direction, right? If those valves are diseased or if they're not working right, you know, if that left ventricle normally pumps blood out to the body, but half the blood goes back up to the left atrium because of mitral valve prolapse, that means we're having a lower blood pressure coming out because less of it is actually getting pumped out to the body. Aneurysms, certainly, whether we're talking about like an aortic arch, thoracic aortic aneurysm, abdominal aortic aneurysms, any of those are just helping us to narrow down our differential diagnosis of what do I think is going on with my patient today, right? So I've got this chest pain patient. All right, well, everything's on the table of possibilities for a chest pain patient. And now that I get a set of vitals, you know, maybe I narrow out a couple things that I don't think it is anymore. Then I get a past medical history and I narrow out a few things. And I get more of a physical exam and I narrow out a few more things. And eventually I get down to a small list or ideally one thing that says, hey, I think this is what's going on with my patient. Now I have a protocol that matches to that differential diagnosis. And that's what I'm going to do, right? Too often, you know, we talk about the cookbook medics, right, where they fall into those bad habits of saying, they're complaining of chest pain, I have a chest pain protocol. It's like, that's just lazy medicine, right? It's a lazy provider, right? You have a chest pain patient, great. Go through your history, your physical exam, your OPQRST, your sample, get your set of vitals, get all the information and say, great, I have a patient that I now know because of a 12 lead, or I highly suspect based off of all my findings that they're having cardiac related chest pain, and the cardiac related chest pain, I think it's a blockage. I think it's an MI. Now I can go to my ACS chest pain protocol and do my aspirin nitromorphine thing, right? But it's not until you get that full assessment that you really narrow down that differential diagnosis to what you think is going on. And then from there you say, okay, this is what I think my patient has. Now I have a protocol that says this is how I'm going to treat that, right? That's how to use your protocols. And that's a big thing that registry is looking for you guys to figure out, right? They'll say, here's your information. What's going on with your patient, right? What's your differential diagnosis, right? A lot of times they'll ask questions based off of that. They'll just give you the vital signs and give you signs and symptoms and give you a chief complaint and give you 4 answers of 4 different disease processes. And based off of all the information, you have to say, okay, based off of all that, that's fitting the pattern for me of a meningitis patient. So I think it's meningitis. That's my answer. So if they don't ask you directly what the differential diagnosis is, the other thing that they'll ask you is, your treatment, right? And so they'll give you a bunch of information and then they'll say, what's your treatment? But in order to choose the proper treatment, you have to figure out what that differential diagnosis is from the information that they've given you, right? So it's still kind of a step that you have to say, okay, this is the treatment I think is right for this patient because this is the condition that I think the patient is experiencing based off of the pattern of signs and symptoms and vital signs that they gave me, right? So it's kind of working your way constantly through, here's the information, what's your differential, how do you treat it? What's your differential, how do you treat it? These medical emergencies chapters, that we're gonna do for the next weeks and weeks and weeks is all about differential diagnosis and treatment, right? So as you're studying these chapters and we go through neuro and we go through endocrine and we go through abdominal and GI, right? And you get into the different sections inside the textbook and it says, okay, kidney stones, right? Then you go through and you read the kidney stone section and say, okay, what are the key signs and symptoms that are unique to this as opposed to the pyelonephritis, which is the next disorder that they talk about, right? So it's really just hammering down what are my 3 to 5 to 6 or however many it is unique signs and symptoms for each disease, right? You can even make flashcards that way. You could just make flashcards that on one side it just has 5 signs and symptoms, right? And you just read the signs and symptoms and say, okay, that's my measles patient. They look in the bag and you're like, yep, measles, cool. That's a great way to work through these medical emergencies because it's all about starting right now with the foundation of just the stereotypical presentation of everything. And then once we get the stereotypes, then it'll become easier to bridge off of that later on and say, okay, now how does a elderly diabetic female present when they're having an MI, right? It's not the chest pain radiating down the left arm, right? It might be epigastric pain is the reason why they called and that's what they're experiencing and they're having a full-blown MI, right? But we're not going to really emphasize the atypical presentations until we get the classic presentation patterns for everything down. All right, sorry, I jumped back a question 15 minutes ago, Casey, sorry. This might be a dumb question. There's a specific lead set that has been found to be related to these syncopal episodes or just patient dependent? Specific lead set. What do you mean by lead set, Casey? Casey? Casey. Well, Casey's gone, so I can't help her. Sorry, ECGs. Yeah, I'm just playing. No specific lead set. Some understanding for like a syncopal patient. I mean, just classically hooking them up with the 4 electrodes. Way stereotypically, I mean, way often we'll just go and look at lead 2. Just because again, go back to some of the ECG stuff that we did weeks ago. Lead 2 just generally has the biggest, P waves and QRS complexes and T waves, so it just becomes a little bit easier to see. But yeah, not one particular lead or sets of leads to look at. When we're just looking at that real quick snapshot of what rhythm are they in. Lead 2, I guess, is probably gonna be your most common, just because of the visualization ability of it. But really it's like, as soon as we can see the rhythm, then, right there with the rhythm, we'll be able to tell if the rhythm is currently causing an issue for the patient. So remember, just because it's the rhythm that we see right now, doesn't mean that was the same rhythm when they had the syncopal episode before they called 911 and we got there. So, cool. All right, secondary assessment, right? Just continuing through the rest of it. We don't emphasize it as much when we do like the ACLS scenarios, like Andrea's going to start doing with you with the CBC LOC. I mean, we do it a little bit initially, but we don't really get into the big physical exam component of the ACLS scenarios. because pretty quickly, as soon as we do ABCs, O2 IV monitor, right there on the monitor, we know it's a bradycardia problem, or it's a tachycardia problem, or they're dead, right? So we don't, that guides our treatment so much more so that a lot of the other stuff kind of becomes just secondary information. Hence the secondary assessment. That was stupid, Andrew. It becomes, ancillary information, we can say that. Just because the root cause of their problem being a arrhythmia problem or a cardiac arrest problem or something like that, immediately answers all of our treatment considerations just by knowing it's bradycardia, so we're doing the bradycardia algorithm, or it's tachycardia, so we're doing the tachycardia algorithm. Where this comes into play even more so is when it doesn't really fit the bill of the chest pain MI patient, and we're kind of continuing down like, I don't think really this is an MI ACS patient, so what else could it be, right? And what else could it be means dig further into your history, dig further into a physical exam, and start looking for some of those signs and symptoms that will then say, boom, there's a little key bit of information that says, this is what's going on. It's like, I have this chest pain patient, but it's not, like, they don't have any difficulty breathing. They kind of look okay. The chest pain, they're not saying it's, that crushing classic pressure, chest pain issue for an MI. Like, all right, well, what else is going on? And then, you get a temperature and their temperature is 102. Like, oh, this is an infection, right? You found that extra bit of information. So it's when you go through and you say, okay, it's not bradycardia, it's not tachycardia, it's not cardiac arrest, and it's not fitting my kind of classic cardiac chest pain presentation. What else could it be? And the what else could it be really gets into dig deeper in your detective work, dig deeper into the secondary exam, the physical exam, the more in-depth history to find out what's going on. So physical exam, if we are saying chest pain patient, or if we've narrowed it down to think that I have a cardiac issue of some sort, then we really, if the patient's still alert and talking to us and able to answer our questions, right, then we can do that more focused physical, which would be expose, look, listen, and feel on that chest, right? And the visualization and palpation, visualization, you'll see, like, you expose their chest and be like, oh, there's hives. It's an allergic reaction. We're going to go down that route. Or you expose their chest and you see the seatbelt or the steering wheel bruise from the car accident that they were in yesterday. And you go, oh, dang, like, I was here thinking medical chest pain, and now I'm seeing this as trauma, right? The auscultation can give you your, pulmonary edema signs, potentially. So that's the inspection and palpation. You can go, it feels like some broken ribs are in there. Like, you have any recent trauma? What's going on? Maybe they say they slipped and fell in the shower earlier. Like, okay, again, now my mind is now going trauma for this chest pain, not my elderly patients having, an MI. Inspect neck and tracheal position. So we can look for the jugular vein distension that they're referencing there. And we can also look for tracheal deviation, right? Which, tracheal deviation has only ever told us one thing in EMT and paramedic school. And tracheal deviation for us is that tension pneumothorax advancing. So if we see the tracheal deviation, we say, okay, this is something happened, but this is kind of a respiratory thing, right? This is actually, we got to needle decompress, relieve that pressure, right? We'll ask some questions after we do this, like, that's a life threat, so we got to needle decompress as soon as we recognize that I'm calling it a tension pneumothorax. So I got to needle decompress. Then I'm going to try to figure out, how the heck did this guy get tension pneumothorax in the first place, right? And then you can kind of follow that detective work at that point. Things like jugular vein distension. What are some JVD causes, right? What could cause JVD?
Tamponade.
Cardiac tamponade is a big one, for sure. It's one of the 3 of Beck's triad, which are our signs for cardiac tamponade. What else? There's another big one from this chapter. see if we can. Tension pneumo EV, I'll give you that. It can absolutely cause a tension, or the tension pneumo can just put enough pressure on that heart and the vena cava that allows that blood to back up. So it shows up on the with JVD. I'll give you that for sure. There's another one too.
Could be like a MI that has to do with the left ventricle, so that blood's backing up. Because not
Right, so let's follow that, James. If the left ventricle is having an MI or something and it backs up, where's that fluid going to back up to?
Yeah, back up to the lungs.
Yeah, the left atrium and then out to the lungs. So the left side fails, you get that pulmonary edema. If you get that right side fails, right ventricle fails, it's going to back up to the right atrium, and it's going to back up from the right atrium into where?
What, the vena cava, inferior and superior vena cavas?
Yeah, inferior and superior vena cava, so we can get our JVD from that right-sided failure, whether it's a right-sided MI, or I think Riley chimed in with inferior MI, potentially. Absolutely, that inferior right-sided MI, or just that right-sided heart failure, that now if that right ventricle is failing, it backs up to the right atrium, which is going to back up into the superior and inferior vena cava. So on the superior side, we'll see it with jugular vein distension. What will that back up down the inferior vena cava show up with eventually, not immediately?
Pedal edema?
Pedal
Pitting
edema.
edema.
Yeah, gravity-dependent edema, which for most all of us is going to be pedal edema. If it's a bedridden patient, they'll say sacral edema, right? Just wherever gravity is going to take it to the bottom. So if they're bedridden, it'll show up on their back. But for everybody else, more than likely, it's going to go all the way down and you'll get the pedal edema. Very good, very good, very good. All right, inspect, palpate chest, surgical scars, right? Any recent history. If they say, yeah, I just had stents, put in yesterday. Like, whoa, crap. What'd your doctor say if you have chest pain now, day after your stents got put in? What should we do? Right, we're going to take that patient to the hospital. Right? So any sort of recent surgery, certainly anything recent that implies maybe a potential for a cardiac surgery, we get that on the physical exam. Hopefully we also got that on our history taking, that if we ask them, hey, past medical history or any recent surgeries or anything like that is another great question. Hopefully that comes up there. Inspect and palpate, taking a look, seeing if they have nitro patches, right? Some of those angina patients, instead of having the little nitro sublingual tablets, they'll have a nitro patch. And you can look on the patch and it'll say right on there usually, 0.1 milligram per hour, right? And that's just the absorption rate of that medication through skin for an average person. They'll actually put that's the dose that is for that patch. It'll say, 0.1 milligram per hour, whatever the number actually is, I don't know. But if they had a complaint of something like a syncopal episode, their blood pressure was too low, and maybe they need that nitro prescription readjusted, right? So we should take that nitro patch off if it's causing the hypotension that we know nitro does. Take that patch off so that the nitro can kind of wear off in their system and their blood pressure will come back. But then be very careful with where you put that nitro, right? You can't just, hold it on the back of your glove or something like that, because it's going to start absorbing through the glove into your skin, and now you're going to go hypotensive and pass out. We obviously want to know if they have pacemakers, defibrillators. If we start talking barrel twisted patients, right? Where do we see that barrel chest description for people? We know who's got that barrel chest presentation. It's in chapter 16, which is next week.
Isn't it COPD patients?
It's some of your COPDers, absolutely. Yeah, some of those emphysema, like chronic bronchitis patients, they'll get that big barrel chest appearance. Crepitus, we know 99 times out of 100 is telling us broken bones, right? That bone-on-bone rubbing of broken bones. The other time that they'll use that crepitus word for you guys, the only other time that they use that crepitus word, is to describe the kind of snap, crackle, pop of subcutaneous emphysema, right? So like something, you know, fractured the trachea and air is leaking out into that tissue, and you can see it just swelling there, and you feel it. And, you know, people say it feels like Rice Krispies. You feel that subcutaneous emphysema. They'll use that word crepitus for that as well. Even in the absence of like broken bones, they'll say that the subcutaneous emphysema feel on assessment, they'll describe as crepitus. All right, palpate the patient's abdomen for distension and pulsations, right? Again, it's just working through, you know, we do an assessment, a physical exam, because the things that we could find mean something to us, right? So if we palpate their abdomen and we can palpate their pulse by just touching on their abdomen, right, it's usually a sign of that abdominal aortic aneurysm, right? We don't just palpate the abdomen because I was told we should palpate the abdomen. We're palpating the abdomen because we're looking for particular signs and symptoms that can clue us into particular traumas or disease processes or disorders that might be going on for that patient. Good. So swelling, pulmonary edema, we talked about, RVF, right ventricular failure, or right-sided heart failure. One-sided pitting edema suggests something's blocking blood flow just on one side. So maybe something like a severe DVT or a blockage in a artery in your leg. Something's blocking blood flow just in a particular spot means the backup of fluid and the edema is going to show up just in the area that's being impacted or affected. So if you look at one leg, right, going back to this one real fast. If you look at one leg and you're like, does that look swollen to you? Compared to the other leg, right? If they both look the same, then you can ask the patient, you can just ask them like, hey, you know, been dealing with any, you know, swelling in your feet or swelling in your legs? Some patients will go, yeah, I have been. Some people have no idea what you're talking about. And it just gets worse and worse, right? If it's right-sided heart failure, right, and that fluid is just backing up, the blood is backing up in their body, that gravity-dependent pedal edema is just going to keep getting worse and worse and worse and worse until something happens either negatively and they crash or positively in that they're getting treatment for it. I remember when I was in paramedic school at Good Sam, Banner University, there's a guy that I went into the room for the assessment. He came in for swelling in a very particular spot, was finally what actually brought him into the ER. And it was such severe right-sided heart failure, or just heart failure in general. His left side had failed well in advance, and his right side was now being impacted. He had had pedal edema that had been advancing and advancing and advancing and just working its way up his legs, up his legs, up his legs. And so we go into the room, and I have a feeling now in hindsight that the nurse knew what was going on, had potentially been in that room already and was just messing with me. But they had me do my assessment, and I started talking to the guy. And his scrotum, no joke, was swollen up about the size of a basketball. And it was just the fluid, pulmonary pedal edema, leg edema, leg edema, leg edema, scrotal edema, right? And it had just swollen up massively. And he was like, I just can't deal with this. I had to come to the ER today. It's like, dude, you needed to come to the ER like a month ago to deal with this edema problem. It just finally progressed to that point that it was so bad, so uncomfortable for him that he decided, I should go get this checked out, right? Which, you know, sounds like a lot of guys, right? They're like, all right, this is now impacting things, so I got to get this checked out. All right, wrapping up our physical exam stuff, we'll take a break here. And the EV I'm going to throw up now. He was like, I got to go see a cardiologist right now. Good. Well, yeah, we'll take a break here in a little bit. Some monitoring devices, ECGs, obviously we know. Don't forget your end-tidal CO2, even if it's just a nasal one, to see how they're doing. Pulse ox certainly as well. All right, so some of the interesting ones. pulse deficit, right? So difference between the apical, where'd it go? Sorry, I lost it on land. Apical and peripheral pulses, which is really a rate thing. That one gets talked about the least. I'd rather you guys make sure you got the definition with pulsus paradoxus and pulsus alternans, just because you'll get asked about those a lot more often comparatively. Pulsus paradoxus, excessive drop in systolic pressure. The easiest way that it would be to see that would be in the hospital setting with a arterial blood pressure monitor. You could see it because what it is saying is when they take a breath in, the blood pressure drops. And so it's way easier to see if you have an arterial blood pressure monitor, where every single beat that goes through, they have a pressure sensor in an artery that's monitoring the blood pressure of that beat, and the blood pressure of that beat, and the blood pressure of that beat, right? So it's monitoring each individual one. It's usually red on the monitor, and it just keeps changing with each beat. It'll just keep giving you a new pressure. And so what we'll see is when that intrathoracic pressure increases, when they take a breath in and it puts pressure on that heart, the blood pressure drops, right? Because the heart can't fill up and push out as much blood in that instance, so that blood pressure drops, right? And they breathe out and they relieve that intrathoracic pressure, and then their heart can expand more, fill up with more blood, and now it can pump out more blood, so it's going to have a higher blood pressure on those beats. So that's your pulsus paradoxus. Pulsus alternans, sign of severe ventricular failure. It's just on a kind of beat-to-beat basis, the strength you're kind of feeling it is different. The other one that you'll get is electrical alternans, which is big QRS complex, and then the next one is a little QRS complex. And then the next one is a big QRS complex, and the next one is a little QRS complex. Some of those are sometimes tied into the cardiac tamponade as well, where you're getting that fluid in the pericardial sac that just keeps shifting around as the heart tries to keep contracting. It keeps kind of moving that cardiac tamponade fluid that's been building up, keeps getting moved around. So in some instances, the way the movement is, it allows for that heart to expand and pump out more blood. And then other times it's heavily restricted. So it's very little expansion and very little blood that gets kicked out. So it just kind of keeps moving around. I will find, make a note of it, I will find a good video that I've shown in the past that really highlights, it actually shows just how severely the heart can start moving around when it's dealing with, when cardiac tamponade is going on for the patient. So I'll find a good video for you. You guys can probably find it just as easily as I could. And I'll shoot that out to you guys in a message. Blood pressure, elevated blood pressure, right? Could be anxiety, could be pain, could be chronic hypertension, right? So we're not too sure until we get some more information. We know the hypotension, right? For us, we're always still using that magic number of 90 systolic. Increased pulse pressure, right? Could be arteriosclerosis, right? The actual strength of that pulse pressure. And then reduced stroke volume, right? So how much blood actually gets pumped out in the beat. Can either be your cardiogenic shock, your heart failure patients, or cardiac tamponade. Again, something is putting pressure on and restricting the heart's ability to expand and fill up with a lot of blood, and then contract and it'll pump out all that blood. So if you have pressure being applied to the heart, whether it's tension pneumothorax pressure or cardiac tamponade pressure, right, or just the heart itself isn't actually functioning properly, right, all it's going to do is just reduce how much blood is actually getting pumped out systemically throughout the body, which means we're going to have a lower blood pressure that way. All right, heart tones, S1, right, occurs when your tricuspid and mitral valves close, right? So those are your AV valves between your atrium and the ventricle. So those valves snap shut. That's the first sound you hear, S1. If you put your stethoscope on and listen to your heartbeat, the bump, 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 the first bump is the tricuspid and mitral valves snapping shut, right? Which means that's when your ventricles are contracting. They snap shut the tricuspid and mitral and open up the aortic and pulmonic so that the blood can go that direction and not back up into the atria. Right? S2 then becomes now the ventricles contracted, push the blood out to the pulmonary arteries or out to the aorta, and now those valves have to snap shut so the blood doesn't just continue back into the ventricles that just pumped it out. Right? So they're going to close behind it so that the blood keeps going forward, and that's going to close off, and then the ventricles are going to start filling up with the rest of the blood that starts coming in from the atria. S3 and S4, right? So S1 and S2 is normal, right, for all of us, right? The S3 and S4 are abnormal, certainly in adults, right? If you hear extra sounds, right, beyond just a bump, 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 if you hear anything else in an adult, it's considered abnormal. In pediatric patients, having like an S3 is usually considered a normal finding for them, and it goes away as they keep getting older. So an extra sound in a pediatric patient is less concerning than it is for an adult patient. Peds, they usually grow out of it. Adults, they developed it because of some other issue. So S3, they say, is caused by ventricular wall vibrations, usually associated with heart failure. And then S4, which is actually before the first sound, the turbulent filling of stiff ventricle and hypertrophy, possible MI. Some people, the book will have, Kentucky, if you said Kentucky, right, for the S1, S2, and then an S3 sound for it, or they give you lub dub da blah, or they'll do weird stuff in your book to try to describe it. It's one that if you get the opportunity to talk to, interact with a cardiologist on a clinical shift one day, or no cardiologist, or go online and find some heart tones audio. Let's see if I can find a good one to send out to everybody as well. Those are good, just kind of helpful ways to give you some context, give you something beyond just words on a PowerPoint or words on a textbook page. Murmurs, again, sound from turbulent blood flow actually through the valves. Again, certainly increasingly more difficult for us to assess just because of the comparatively infrequency of patients even having them in the first place, coupled with the infrequency of us really using it as a diagnostic tool to help us with the differential diagnosis. Right, once we kind of check off our boxes of it's not an MI, it's not something that's going to kill you right this second, we don't have any bradycardia, tachycardia, chest pain issues that we're treating in ACLS, right? We've ruled out all of those other things, is really where most all of us kind of take that breather and we step back and say, okay, let's get you to the hospital. And the ER is going to say, yep, you're not bradycardic, you're not tachycardic, you're not having any arrhythmias. We're going to refer you to cardiology, right? That's going to be the sequence of a progression there. And then you go to a cardiologist's office and they really will listen to heart murmurs, and they'll do a bunch of other assessment things to try to really narrow down what it is that's going on for their particular patient in a more kind of in-depth cardiac assessment to really get to it. But no heart murmur is going to shift us from one differential to another differential diagnosis, just for the kind of criteria and the things that we're looking for and evaluating for patients. And reassessment done on the way to the hospital. Repeat everything we know. Certainly notify the hospital, right? If you have a STEMI patient or a patient that you think is that, they want to know ahead of time, just so they'll be ready to go. We'll bring that patient in. More than likely, they're going to slap on their own 12 lead really fast and say, yep, it's an MI. And just in that process, they just keep wheeling them straight to the cath lab. Right? That's ideally the sequence that would happen. Is we might courtesy notification the hospital and say, hey, we're bringing you a 65-year-old male complaining of chest pain, has past history of 3 MIs, says this chest pain feels just like those. I'm seeing a STEMI, I'm seeing ST elevation on V1, 2, 3, and 4. We'll be at your facility in 5 minutes. We've got oxygen, aspirin, nitro, 3 rounds on board, and we've got our first dose of morphine or fentanyl on board. We'll be there, like I said, in 5 minutes. And great, you get there in 5 minutes, the hospital will be waiting for you. They will have activated the cath lab and done everything that they need to do internally. They'll get the patient onto the hospital bed usually. Sometimes some places will have the ambulance crew just continue taking that patient straight to the cath lab. Otherwise, they might move that patient, run another 12 lead, confirm it on their side, hand that 12 lead right to the cardiologist and wheel them straight into the cath lab, right? That's that door to cath lab or door to balloon or door to thrombolytics, those clot buster medications. Those are all those kind of time intervals that they're evaluating to make sure that we're not ever delaying that patient unnecessarily. When we know it's chest pain, we've got the 12 lead that says STEMI, we confirm it at the hospital, they see a STEMI, and then we roll them right into the cath lab to treat the STEMI, right? We don't want to delay that patient at all. All right. The next part gets into the whole electrophysiology section, which is actually going to serve as a good kind of stopping point for this cardiac section right now, because pretty much all the electrophysiology, we'll lecture some of it, just because some stuff that is a bit more in depth now that we got all the rhythm identification under our belt, we'll go a little bit more in depth into some of the electrophysiology stuff. But then we're going to bypass all of the slides and all the pages in chapter 17 that identify or that talk about how to identify rhythms, because we just did all that. So I'm not going to lecture that again to you in one sort of blitz that's going to go through everything. And then after the rhythm identification, it gets into ACLS algorithms, and then angina and arteriosclerosis and chronic hypertension and endocarditis and pericarditis and a bunch of all the other stuff is the back half. So we kind of had the first third of this chapter was A&P and your assessment. The whole middle section is rhythm identification. And then the whole last section is the other cardiac emergencies. So it's just a good kind of stopping point for this stuff right now.